This is actually a case that I did when I was a resident. I worked with a guy who he did a lot of venous TOS at Tulane in New Orleans, and he used to do paraclavicular incision. And then I always remember, how he was able to take a nice big piece of the first rib instead of just, piecing it out. And I don't do, I rarely do thoracic outlet. It's not an operation that I'm very, very interested in. But the incidences are up to 2%. Usually we see it in the younger patient population. And it's one of the few vascular problems that we see in our profession that's more common in females. Usually everything else is more common in males, all the vascular stuff that we see, but this is one of the few. And there was an article in I think it was one of the cardiac journals, saying it's one of the most litigious conditions. The problem is that these patients get bounced out from person to person, and then if you don't do a complete operation, they're miserable after that, and so it's a very litigious problem or patients to be facing. So be careful. So there are some other names. Some people call it cervical rib syndrome, scalene antecus syndrome, costoclavicular syndrome, hyperabduction syndrome. But basically, TOS refers to a spectrum of syndromes related to the thoracic outlet. So this, if you look at the thoracic outlet, basically, it's almost like this entire area. So you have the area between the spine, the first rib, and the clavicle, and you have also this area here. And I'll talk about individual ones in a second. So the anterior scalene, we did some dissections on the cadaver on Friday, right? You guys took the anterior scalene down. So basically, the anterior scalene originates from C4, C6, and it inserts on the first rib, right? And that's why when you take the first rib, you have to take the anterior scalene. And same thing applies for the middle scalene, right? We saw the middle scalene also on the cadaver. So the middle scalene does the same, but not the posterior scalene, right? It goes to the second rib, so you don't have to worry about it. But also, some people take out the middle scalene too when they take out the first rib. So if you look at the thoracic anatomy, so the brachial plexus is formed by the ventral rama of spinal nerves C5 to C8 as well as T1. And the subclavian artery, along with the subclavian artery, they go through the interscalene space, which is the anterior, which is between the anterior and the middle scalene, this space here. And then eventually, now the vein joins in this space here, basically the clavicle, which we call the costoclavicular space, through the pec minor insertion. And that's why, also when we dissected on the cadaver to expose it, we had to take down the pec minor, okay? Also, we talked potential, you guys know what this is? Those round yellow, these are the sympathetic chains. So these are the ones that you could injure. We talked about on the cadaver when we dissected the vertebral artery, that you could potentially injure the sympathetic chain and cause Herner syndrome. What about this nerve? Going around the current laryngeal, right? So this is the right side. What about the left side? Goes around what? The arch, correct. And this nerve? Phrenic, right? And then we talked about on the cadaver how it goes from lateral to medial approach. So, if you divide this entire thoracic outlet, you can pretty much divide to three space, which is called the scalene muscle space, the costoclavicular space, and then the pec minor space. So I'm going to show you each one. So the scalene muscle space, we pretty much talked about that it's bounded by the anterior scalene, middle scalene, and the first rib. And then it's the most common site for the neurogenic TOS. And also you see with arterial TOS, but it's more common for the neurogenic. It has the brachial plexus and the subclavian artery. So if you look at the costoclavicular space, which is basically bounded by the clavicle, subclavius muscle, and the first rib, and also the costoclavicular ligament. And this is the area where, especially athletes that use their shoulder a lot, pitchers, swimmers, volleyball players, it gets really hypertrophic, and that's what happens. It gets really tight area. And obviously in this area we have all three that pass through, and then the vein is the most commonly compressed in this area. Pec minor space, basically the pec minor, you have the pec minor anterior and the chest wall posterior, and then when we think of the pec minor space, it's usually it's common when we have patients with recurrent neurogenic TOS. I had a lady that came a year ago to see me. She had been treated by a friend of mine, did well for a year or two, and now her symptoms are back. And then as soon as I put my finger in the delta pector groove, I was able to reproduce her symptoms. And just for education purposes, I injected her with a bupivacaine, and she had relief for actually almost 3 months. And then we brought her back a couple months ago, and we basically resected the pec minor. She's been doing great since then. So think about it when you have recurrent neurogenic. So this is what I just basically talked about the pec minor recurrence. So again, so again, you see all these beautiful structures, but again, think about it. This is a very dynamic area, right? This is a very dynamic area. I mean, there's really no minimal room in all these spaces. So add inflammation, trauma, right? Clavicular fracture, add osseous changes, right? Long transverse processes, cervical ribs, incomplete cervical ribs, soft tissue changes. So you can imagine how eventually all this stuff will add up and cause problems in that area. So for example, this is a cervical rib displacing the brachial plexus. And also it's impinging on the artery. And a lot of times you see when we do the arterial segment that you have what we call post-stenotic dilatation. Okay, so you probably know this, right? Neurogenic is the most common, venous second, and arterial is the least common. But if you deal, I don't know if you guys have a children's hospital, but if you deal with a children's, I don't know, maybe less than 18 or something, actually venous is also as common as neurogenic in that patient population. So when you see these patients in clinic, it's very, very important to ask them, look at their body habitus, their posture, what kind of work they do. Because usually a lot of the pathogenesis behind the thoracic outlet is that, so you have your hyperextension injuries or activity where they have, they do a lot of work with, arms above their shoulder or hyperextension and abductions and, or in addition to some abnormalities like we talked about, some of the cervical ribs and the osseous changes. So any of those, could lead to these hyperextension injuries, whiplash injuries, shoulder hyperextension. Patients that have also, that sit at the desk and do quite a lot of work where they're in a static posture. Sports, as we talked about. So these are just some examples. You're going to see probably some of that stuff repeat in the upcoming talks too. Athletes. Again, this is a picture showing the compression of the subclavian artery with what we call post-stenotic dilatation and aneurysmal changes. So cervical ribs occur in 1% of the population. Again, more common in females. If you have it, okay, you're 10 times more likely to develop TOS. But doesn't mean if you have it, you're asymptomatic, you should go after it, right? So, but if you have it, you just educate the patient, say, well, you know what, you're more likely to have TOS. And these are the symptoms. If they do, come see us. So, but that doesn't mean you have to take it out. It's 50% bilateral. And then, although most of them are incomplete or rudimentary, most have ligamentous attachments to the first rib, like this one here on the other side. So this is a complete, and this is what we call rudimentary one. And like I said, most cervical ribs are embedded in the fibers of the middle scalene and displace both the artery and the brachial plexus, as you can see. So basically, the rationale for the first rib resection is, you have abnormal ligamentous and muscle attachment to the first rib, and you basically just want to take it out. And when you take it out, usually we take a big piece of the muscle with it, because actually muscle tend to kind of regrow. So like I said, so 50% bilateral, you're more likely to develop problems, but doesn't mean you go after it. The only time, again, I'm not sure if that's in Rutherford, since you mentioned Rutherford, but the only time you might consider taking it on the other side out, if patient had it and they embolized, then you don't want the same thing to happen on the other side. You might, again, this is a soft call. I'm not saying you should go after it and take it out, but usually we just leave it alone. Again, these are just pictures showing you complete and incomplete rib. Again, compression with post-stenotic dilatation. again, other abnormalities while you're there, right? Make sure when you do these operations that you rule out these other abnormalities. A lot of that stuff you can take out at the same time. If there's a long transverse C7 process, if there's a clavicular malunion, also poor posture, which I have unfortunately working with the loops and bending over and stuff like that. So make sure to remind yourself to have. That's why they go through physical therapy, especially for the neurogenic. And also look for soft tissue abnormalities like congenital fibromuscular bands and ligaments, scalene minimus, which I have a picture to show you, the hypertrophied subclavius muscle, and the narrow cluster of clavicular space. All the stuff you need to take down when you do your rib resection. What is that nerve running behind the middle scalene? Yeah, I think I heard someone say it.
Speak up.
You're right. It is a long thoracic nerve. Yeah. So again, you have to be careful. Again, like even on the cadaver, when we do dissection, right? I told you not to grab the whole muscle and cut it or bovie through it. It's always a good technique just to take a few fibers at a time, because generally there's some important structure sitting behind most muscles that we take down. So you have the long thoracic nerve, scapular wing. Also, you have the phrenic nerve, you have the sympathetic ganglia, which we talked about. These are all potential nerves that you could injure. Thoracic duct, right, especially on the left side. Again, this is showing the cervical ribs. So then, real quick, I'm just going to go through some anatomies. I should have probably hit the answers. But again, the axillary artery, it basically becomes the subclavian becomes the axillary artery at the lateral edge of the first rib, right? That's what we also talked a little bit about the cadaver. And it's divided by 3 parts of the pec minor, because that's what you take down, right? You take down the pec minor to expose the axillary arteries, And as a general rule, the first segment has 1, the second segment has 2 branches, and the third has 3. And then the brachial artery, or becomes a brachial artery at the lateral edge of the artery major. So the way I remember it, minor, major. I don't know. That's minor, major. So that's how I remember the transition in case you get asked. And then obviously it branches into the ulnar and radial. Usually most patients below the elbow, but a lot of times, if you do a lot of dialysis work, a lot of times we see patients where they have high takeoff of their radial artery. Again, this is just a picture for you guys. Venous anatomy. You guys pretty much know all the stuff. Cephalic, basilic from the venous anatomy. So this is your median antecubital vein. A lot of times also we use it for dialysis, for when we do like brachiocephalics, I use it a lot if it's there. It's also very important to, when you do dialysis work, to look at the entire vein, look at it, make sure it's not sclerotic before you use it. And also, I think it's next. So this actually came out from Methodist, where they do, one of my partners, Eric Peden, does a lot of dialysis work. So they actually looked at it, because a lot of times you do a first stage basilic, and then you realize that the basilic literally that far in joins the your deep system. I mean, you can, if you want to mobilize the brachial vein and transpose it, you can, but I don't think I don't think it's a good idea. So a lot of times you want to make sure that if you do that, if you're going to mobilize it, make sure they have either another paired vein or not. So, or maybe duplication of their system. Like for example, in this case, see how you have only one unpaired brachial vein, and then that's not unusual. So that's why it's important for you guys to do the ultrasound, before you do your first stage. So like, for example, in this case, I have no problem transposing it because there's another paired brachial vein. So, importance of ultrasound that you guys can do it. I'm running out of time, but you guys know if you injure those different nerves, what happens. Again, it's very, very important, right? Especially when you have patients with steel. When you examine the patients, look for these, wrist drop, interosseous, so they're able to move their fingers or not, and kind of tell your faculty. It looks better when you actually know what you're doing, which nerve you tested, what kind of problem, and then relay that to your faculty. You always look pretty good when you do that.